Good afternoon and welcome to the Health and Overview Scrutiny panel. I'm Councillor Leonie Oliver and I'm the chair of the panel today. Thanks for coming out in the rain. It's delightful. Okay, so we're live now. So if the continuous fire alarm sounds, please evacuate the room and public gallery by the stairwells. Do not attempt to use the lifts. Please assemble at Queen Victoria statue in Guildhall Square. In order to comply with Guildhall Trust Fire Marshal regulations, anyone who signed in at the Guildhall reception desk should sign out when leaving the building at the end of today's meeting. I draw your attention to the fact that this meeting will be live streamed and everyone speaking, please do so via the microphone and the camera will be on. Members of the press and public, which we don't have any, but are also permitted to record the meeting on the understanding that it neither disrupts the meeting nor records those stating explicitly they do not wish to be recorded. Please can everyone remember to use the microphones and remember to switch them off at the end. Let's go for introductions. I'll go around to my right first.
Lisa Gallagher from Democratic Services.
Good afternoon, Councillor Matthew Cordy, member for Hilsey.
Councillor Susie Horton, Central Southsea Ward.
Mark Jeffrey, Councillor at Portsmouth City Council for St Thomas Ward.
Councillor Graham Heaney, St Jude Ward, standing in for my colleague Judith Smythe, who can't be here today.
I'm Gillian Harris, a councillor in Havant Borough Council.
Welcome, everybody. Right, so we've got apologies, as Graham said, from Judith Smythe and Councillor Minahan as well. Oh, mystery. No worries. Oh, bless you. Take a few. Can I just ask if anyone has any declarations of interest for today's meeting? Nope, brilliant. Agenda item 3, minutes from the previous meeting. Has anyone got any corrections or objections? And if they're all fine, can I? Oh, yep, go for it.
I just want to say I think I was there. I've got it in my diary, and I remember there was a lot of. I'm not recorded as either apologies or present, and I'm pretty sure I came. Thank you.
Okay, brilliant. Thank you. Other than that, can I have a proposer and a seconder? Mark? Perfect. I'll second, that's fine. Are you ready for an introduction?
Yes.
Okay, so agenda item 4, the public health update. Can I welcome you to the table, please? Please assume that we've read the report and then just give us a brief summary. Thank you.
Thank you, Chair. So we'll quickly introduce yourselves. I'm Helen Atkinson, I'm Director of Public Health. I've brought Alan Noble, who is our principal in public health, specifically around leading the work that we do on drugs and alcohol. Specifically, I'm not suggesting you're going to ask any questions or or encouraging you, but because obviously in this report, which I'm taking that you have read, you'll see that there has been quite a significant increase in drug deaths, particularly in Portsmouth and Gosport. So I thought you might ask some questions, so I decided to bring Alan with me. So just to say, as you know, we bring an update on this report every 6 months, so you're very familiar with it now. It includes pretty much all of our statutory mandatory contract services that we deliver. Of interest this time is that we have taken the lead for community development work in the council, so we've added a section on that this 6-month report, but I think pretty much everything else is as normal. There were a couple of things I thought I would just mention. Just quickly, so we've been under OHID, Office of Health, I always forget, Improvement and Disparities, who are basically Department of Health and Social Care. We've been ourselves in Southampton on a deep dive process because we are significantly we're significant outliers for HR2s, which are health visitor checks for ages 2 and 2.5 2.5 years. So we've been under significant assurance, and they've been working with us on a monthly basis. And I just wanted to say, because we were, Southampton and Portsmouth were the outliers for the whole region, been some really focused improvement work with the provider, who are now part of Hampshire and Isle of Wight Community Foundation Trust. And there's been some significant improvements. So the overall target we have to get to for Portsmouth is 72% of children at that age seen. And we are now at 70% and I do want to thank the provider because they've worked really closely with us. So there was that, but also I thought particularly if Susie was here, she'd be interested because she was one of the people that championed this. We have been doing a lot of work around free period products in schools, and it's just been announced that we are the third highest uptake in schools in Portsmouth against the whole country. So I just want to mention that. So that's a really good bit of news. And the final thing is we've been working really hard, and it's in the report, but this particular bit isn't, on our encouraging quits of smoking and our wellbeing services. And we've been part of a regional alliance piece of work in January, and we've just had our what we call our, and it was in QA Hospital and also Pompey Centre, events to try and encourage people who perhaps wouldn't normally. And we had 14 quit dates set. Now that might not seem very much for a whole day's work, but that's quite significant and one of the highest, I think it is the highest in the region, to actually get people to come along who haven't been perhaps prepped or know that they might be at the Pompey Centre or at QA, and for them to actually agree to set a quit date with us and then come to our service is quite significant. So those are, I didn't want to just start on the good news because there is obviously not so good news, which is why Alan's here, but I just thought I'd mention those few things, but otherwise happy to take questions.
Can I just ask about the free period products for girls? Is that primary and secondary schools, or like as in junior and secondary, sorry, or is that just...
I think it is all
Yeah?
schools, yes.
Okay, cool.
Yeah.
Brilliant.
We've also used the products around Portsmouth and others, but that's specifically with schools. So there are in ladies' and gentlemen's toilets around the city.
Let's fire away with the questions. I've got some, but Mark, you can go first. Go for it.
Thanks. I guess actually, obviously, the drug-related deaths is highlighted, and I highlighted before I came here today. And there is a sort of general, I guess, analysis. But actually, you know, you're here, so could you go into a bit more depth about that? Because on the face of it, you know, there are other cities like Southampton that are in this chart, and we've got a very big spike. Thank you.
Thank you. So just to say, my name's Alan Noble. I'm lead on the drugs and alcohol work. I have done so in Portsmouth for quite a number of years, and we have had ebbs and flows within our data. As it stands at the moment, for the drug misuse deaths, we are the 9th worst unitary authority in the country. However, just to caveat it, we are talking about relatively low numbers where a change of 5 or 10 can make a big spike, and that's essentially what has happened with this data. I'll go into a little bit more depth if you're happy for me to. So in terms of the numbers of drug misuse deaths, this is over a rolling 3-year period. The number for Portsmouth was 68 over that 3-year period, and that is an increase in 16 from the years before's rolling 3-year period. So they take it, so this is the most recent data is 22, 23 and 24 combined together. So it is a significant increase, but when we compare it to, say, for example, alcohol-related deaths, it's a much lower number. What's driving the increase is a range of things which I've kind of listed within the report. So we've seen changes in the drug supply. Portsmouth in particular has been unlucky in that we've had, at least on 3 occasions, some quite in the last that 3-year period, contaminated batches of heroin which came into the city, contaminated with nitazines, which are up to 100 times stronger than heroin. That makes them much more unpredictable, which means no two doses are the same, so people could be potentially more prone to overdose. Southampton, for example, hasn't had those same incidents that we have. Gosport has had similar incidents, but not as many as Portsmouth. And other areas within Hampshire have managed to escape any similar incidents. So in one incident we had 5 deaths within a 2-week period. So 5 deaths, obviously, in the scheme of 68 deaths, does skew the data. What we do see is that a lot of there are not a massive amount of deaths for people who are in treatment. So if people access our treatment services, on the whole, they don't die. The ones that do tend to die of long-term health conditions, which have unfortunately been accumulated from 20, 30 years of drug use. And that can often, actually, it's related to things like COPD or liver disease or heart disease, where they're don't want to term it lifestyle, because it seems as though it's a choice, but their way of living over a long period of time has led to that. Probably the biggest driver for drug-related deaths is deprivation. So it's no surprise if you look across the country, the most deprived area in the country, Blackpool, has got the highest number of drug-related deaths. The least deprived areas in the country have amongst the lowest drug-related deaths, and that's a pattern. But it doesn't explain why Portsmouth is 9th worst in the country. I've alluded to some other aspects within the report. We do import quite a lot of people into the city who have got history of drug using behaviours. People come in for treatment. We've got a couple of private rehabs. They often resettle in Portsmouth. It is a relapsing condition. People will relapse, and unfortunately, after a period of abstinence, whether it's through treatment or prison or what have you, then the risks of overdose are higher. Does that explain some of the context?
Yes, it does. Is there any sort of action plan from this, or is it so what you've said is very helpful and clear. It's not the term sort of business as usual, but actually does anything change, or actually is it the analysis has been done that actually it could be a spike or because of the things that you mentioned, so actually carry on as we would do normally?
Yes, so there's we identified the issue as part of our Combating Drugs Partnership. That's a multi-agency partnership that Portsmouth has. Well, each of the areas they have different names to them. Each of the unitary areas do. We've identified it as a priority and a requirement to develop an action plan to reduce the numbers where we can. The biggest protective factor is to get more people into treatment. And we have been doing that over the years. And I think that there's numbers demonstrated within in the report of the increase, and we've further increased our numbers in treatment since we provided that data. So over 2,100 in treatment as of now. What we haven't necessarily been so good at is getting more of the opiate users into treatment, the injecting drug users. So we've had slight increases in our numbers, but actually most of the numbers have been alcohol-dependent drinkers, non-opiate users, so crack cocaine users, and ketamine users. So we've been really good at getting those people into treatment, but not so much increasing opiate users. It is a national issue. Nationally, the numbers have reduced. In Portsmouth, we've seen a slight increase. But that will be our main priority, to try and focus on getting more of those opiate users into treatment. There is something called unmet need. There's a tool on the national database system where they look at an estimate of an area's number of opiate users, opiate and crack users in Portsmouth. That's just over 1,500 is the estimate. In the city. And we have around 750, so about 790, sorry, who are in treatment within that. So our ratio is of unmet need is around 44%. So 44% of our opiate and crack user population are not in treatment. That's actually quite good compared to the national average, where it's more around 54%, and it's significantly better than our areas around, which does kind of run, I guess, counterintuitively to our drug-related death rate. But obviously, I've explained there's a whole raft of factors around that. But we will be seeking to improve our unmet need rate further so that we do get more opiate and crack users into treatment. That's one of our main focuses.
Can I? How do you find out about dodgy batches? So these 5, were they in treatment? Do you know that these 5 that died, were they on treatment, in treatment? What does the city do? If we know we've got a dodgy batch, how do we protect our...
Yes, so quite often what happens is we get intelligence through our drug services that there have been overdoses. That's what occurred on that particular scenario. There were reports for people coming in through our needle exchange or what have you, saying, oh, there's 4 people overdosed at this particular address and there's a dodgy batch. Other people coming in saying, I've used and it was much, much stronger. But also, I mean, essentially, we start to get reports of deaths. So the police will contact us and say a death has occurred. And along with that general intelligence picture that there's strong overdoses, there's overdoses occurring. I mean, I think in that particular 2-week period, we had over 50 overdoses reported. So the fact we had only five tragic deaths, but it was could have been a lot worse. And part of that is, and we kick in with action plans immediately. I mean, there's things that we do on an ongoing basis. So we provide naloxone to our drug-using population, to their carers, to the hostels, to workers within different settings. So recently we bought some for the street pastors that go out on a Friday and Saturday night, for example. And that works as an antidote to heroin overdose and allows that time for people to call the emergency services and to get treatment. I mean, that's provided routinely anyway, but we will surge doses of that, you know, should we have incidents. We've recently, the police have taken on carrying nasal naloxone, which is different to the syringe form that we often provide, easier for them to carry and use. So I think I may have gone up.
Any other questions? Yes, go for it.
Sorry, just I don't mean to be too local, but I'm from Gosport. So you said that there were 5 bad batches of drugs in Portsmouth, and that's led to an increase. The increase in deaths in Gosport seems even steeper. Can you give me some numbers on that, or some are there different reasons there?
I could probably provide you the numbers separately. I'd have to go into the ONS database and do that. But you probably need to bear in mind, if it's low numbers for us, it's probably even lower numbers for Gosport, and therefore, but it skews your rate if you get an extra 2 or 3 deaths.
So it could just be that same 5 deaths, but because we're starting at lower value, it looks a lot more.
I mean, it's still a high rate per head of population, but it's low numbers, so a few extra deaths. And I am aware Gosport has been impacted by contaminated heroin in the town, and there was a whole partnership approach. I think they called it Clear Hole Build, and a number of people have been sent off to residential rehab to try and avoid people who are at risk of overdose. So yes, why Gosport and Portsmouth are significantly worse than the other areas, I cannot fully explain.
Can Can I just ask about the kind of the in treatment, what the in treatment looks like, and do you have the capacity? If we would, you say they've got 45% not in treatment. Are they inpatient beds, or are they a scheme? Just because it's all well and good these adults, young people, if they might be, joining the treatment, but what does that actually look like?
We have a very comprehensive treatment pathway within Portsmouth. At the sharp end of things, harm reduction work is a really key function of what we do, and that's preventing the spread of bloodborne viruses, providing providing naloxone as part of an overdose prevention, providing overdose prevention workshops and teaching. We used to do rave outreach as well, but as the rave scene isn't quite what it was in some parts. So there's that kind of real harm reduction focus. Then that's to try and engage with people and try and encourage them into treatment. Typically for opiate users, the first line of treatment is around substitute prescribing. Now doesn't say they can't go straight for abstinence, because there is that option and people can, but typically they'll substitute prescribing. Traditionally it was methadone. Increasingly we've been prescribing buprenorphine, which is has less of a the best way of putting it, gives less of a buzz, less of a high, and enables people to go about their lives normally. And it will also have a blocking effect. So if people use heroin on top, it blocks the receptors. So there's less of an incentive to use on top. Whereas methadone, you will often find, as certainly in the early stages, people using on top. We've also started doing something called Buvidal, which is a depot injection form of buprenorphine, where people can have a weekly or monthly injection, and that's proving very popular. The difficulty with it is it's significantly more expensive to administer and to provide than methadone. So we do have a cap on the numbers, which we would like to provide more of, but we don't really have the funding to do so. Sitting alongside all of that, there's a whole psychosocial intervention programme. So there's group therapy, there's one-to-one counselling, there's peer-led support groups, which Portsmouth in particular has got a really well-developed programme of, and often people will engage with that peer support more readily than, say, some of the more formal psychosocial structured support. We've got groups, so for example, there's a women's service called Project W, which very much fits within that and is a really great resource. Then we've also got the ability for people to go for the inpatient detox side of things, where they will go to a unit and be detoxified off drugs using appropriate medication and medical facilities to do that, or residential rehabilitation. So less complex cases can undertake their detox within a residential rehabilitation unit, and then they stay for a period afterwards to do the psychological work and the work around how they would manage things like triggers if they are out and about. And then there's a whole load of aftercare afterwards. And again, we've got really well-developed peer-led provision where people can volunteer as peer mentors. They can there's sports programs, there's some arts and therapy work that goes on. And then we've also got something called rework, which is IPS, individual placement and support is the government's term. We've called it rework locally, which is around getting people into work at the end of it. And actually, we do employ a lot of people in recovery within our treatment system, because quite often they'll give hope and inspiration to the people coming in at the front end. So yeah, there's a really well-developed level of provision in the city. We often get feedback from people that visit that are quite envious of it, which again doesn't really explain why we've got a high rate of drug-related deaths. But
do you have any figures for our neighbouring counties in like haven't? Are we? I know like we've got Portsmouth and Gosport that had that kind of the increase, but has that side of the island done the same? Do you know? I know it's not obviously in your report.
Within the Office for National Statistics data for drug overdoses and drug misuse deaths, it does break it down by borough level.
Okay.
Within terms of the treatment numbers of people in treatment across Hampshire, that I only have access to Hampshire-wide data, which is available to me.
Thank you. Thanks for that. It's really interesting. And optimistic that when people are in treatment that there is a high level of success. I've got a really straightforward question. We were in a full council meeting the other day and somebody said that the national funding for drug and alcohol rehabilitation, all the, presumably the services that come out of that, has reduced. Is that, can you give, it's a genuinely straight question, is that true? And if so, what are we doing to try and maintain the level of services, which sound to be quite impressive, in order that these statistics are mitigated against?
I think technically there's at a national level, there's a very slight increase in the funding. Obviously that increase doesn't keep track with inflation, so therefore it's a real terms reduction, but there is a slight increase. However, the formulas which the Department of Health have used to allocate the funding to each individual area has changed. And for Portsmouth, our grant funding that we've received, which has been over and above the public health grant for the last few years, is going to reduce. However, for some areas, they will see an increase. Partly the reason is because our grant funding was front-loaded, so we maybe got a big increase 2 or 3 years ago, whereas other areas, for example, Hampshire, didn't get as such a big increase 2 or 3 years ago. So now what's happening is some of the funding's being reallocated from those areas that got the money earlier to the areas that didn't get it. So ours is reducing, Hampshire's is increasing.
And a quick follow-up on that, is the formula not evidence-based, and therefore if your numbers are going up, is there no, do we have any opportunity to make representations around the fact that whilst we have a net decrease in our funding, that actually, given the data, that we arguably need more?
Do you want me to answer something? Well, you can come in if you don't agree with me. So they are badging it as base. I do get what you mean, Susie, about evidence. There is part of that, but ultimately there was a set amount of money that was committed over a period of time. So what OHID or government is saying to us, DHSC, is that they have now rolled it was a separate grant, both for tobacco and for substance misuse. They're now rolled it into the existing grant. So we've been given a 3-year allocation for the public health grant, which now includes those 2 areas. And the assumption being that we have to manage it within our budgets, but also we can therefore locally reallocate some of the other money within the grant to build it up. Now we're doing that work now. We've got a 3-year allocation, which we only found out a couple of weeks ago. We are now working with our finance colleagues to basically manage the whole of the budget and how we're going to, because we've got several other areas to commission, sexual health, children's 0 to 19, to make sure, but we are working to be able to prioritise drugs and alcohol, because it is a big service for us, because as Alan rightly said, we do import quite a lot of people. I do think it's important to say, because we can, I'm sure Alan can get the link of the ONS data sent to Lisa, so you can send it out, although you can also go to your local commission. And I do want to say that we work incredibly hard across, and Alan's a good example of that, Hampshire and Isle of Wight, all the upper tier local authorities, and the commissioners work really well together, both in terms of how we are commissioned, but also in terms of sharing information. So we do have out of hours reporting mechanisms. So for instance, if we get a drugs death in Gosport, or it's out of hours, it is notified. And we also work incredibly hard with the PCC, Peace and Crime Commissioners team, because obviously they have an interest around, and also obviously with the police very closely locally. So we have all 4 upper tier local authorities, and across the country everybody does our Combating Drugs Board, where Alan leads that work to ensure we're doing everything we can to mitigate, to prevent, but also we then work up at Hampshire and Isle of Wight level to ensure that we're working with our colleagues in the police and the PCC to do everything we can. And I think it's been really successful. However, this is always an area that more keeps happening.
Can I just ask you, when you say import, what do you mean by that? Is that importing drugs or
Both drugs and people? There is. Well,
Yeah,
I'm going to.
I think import's probably the wrong term, because that means we're pulling people in. It's not really that case. That we have got private rehabs in the city which sell their service around the country. We don't have enough money to fill those centres with our own clients, so they are bringing people from London and other areas all around the South and Midlands to Portsmouth to do treatment. Quite often when people come away from the area where they've had a lot of trauma and a lot of drug use and a lot of associations, come to a new area, they want to resettle, to start a new life. So it's a natural thing to happen. Also, we do have a number of private housing providers funded through enhanced housing benefit, providing recovery support for people, and they will be looking to fill their beds through their business model, and often that will be not with Portsmouth residents. So we attract people in. Similarly, and it's a concern I think probably with the change in homeless service provision around Hampshire, people do naturally navigate into Portsmouth because of a high level of hostel provision, homeless day service provision, and generally the voluntary sector provision that there is around. Within the city, people will see it as an option. So we do import people through that way.
Yeah, thank you. I was looking up on the news website, as you probably heard, so apologies for that. Because I can sort of remember, I know it's 5 years ago now, that there was a report about the figures hitting sort of like one of the highest in the country. It was 14.9 back then in 2019. So it was the figures between 2016 and 18. But that's different from the record here. So the 5 related deaths that you mentioned due to sort of batches. Is that something? You might not know this information, but is that something that's just come through on our rolling 3 year, or is that something like 9 months ago or 12 months ago? Does that make sense?
Apologies. That specific occurrence happened in August 22, so it's within the 22-24 figures, and it won't roll out until the next year when it will be 23 to 25 figures. That 14.9 is a rate, so it's per 100,000. Those incidents probably do also mask a general increase in deaths. Another factor is that we see a lot of increasing number of older drug users with complex health conditions, and we're also getting younger people with more complex health conditions occurring, say for example with ketamine use. So that's a slight change, and one of the areas we really need to focus on to try and improve our offer of a general healthcare offer within our services. So we're engaging with the ICB around how we can do that, so that people, mainstream people, if you like, for want of a better term, have challenges accessing GPs. For our client group, it's very, very challenging. So we and then lots gets missed, and lots of health conditions get missed. So it's definitely an area of focus for us as well.
The other question I had, which actually is just really sort of so that I'm aware in the future, is how do you separate categorising a death between alcohol-related or drug-related or mental health issues, and do people get double counted statistically? I guess not, but I don't know.
It's the coroner that determines whether it is. Now they may say, so if the death is a drug poisoning, that will be the cause of the death. It's a heroin overdose, that's what led to them dying. If it's a drug misuse death, that can have a much wider reason. So you could have a death by suicide, which is linked to prolonged use of drugs, and that would be classed as both a suicide and a drug misuse death. I just very quickly wanted to say about the funding aspect. So we do have a good relationship with the Police and Crime Commissioner, and from next year they're slightly increasing the amount of money that they put in, that they give to us to contribute to the criminal justice part of our service provision. Similarly, probation have recently put some additional funding in. So they're mitigating some of the reductions that we will have. But we will be prioritising those drug users at risk, because reducing drug-related deaths is going to be our top priority.
Any other questions? Graham?
It's not on this topic, is that okay? It's a completely different area. No, it's not a drug-related one. I've got another.
Report? Part of the report? Yeah, go for it.
Completely different section. Can I say thanks, Alan? I mean, that's been really interesting. I learnt an awful lot from what you said, and I have to say I'm really impressed with the work you do and how you present to us, because it really helps us to understand some of the complexity and some of the challenges you have to deal with. So thank you very much for that. That's really helpful. I just wanted to refer to this. There's no page number, so I'm going to have to refer to a section. It's called Children's Healthy Weight. And something that struck me very much at the bottom was the very last comment, and it said the number of obese children doubles during primary school years from 11.2 to 24.7. And I wonder if we have any understanding of what's driving that.
So we have. Thank you, Lisa. So it's quite difficult, obviously, to get data on this. We have a mandated national measurement target that we have to work with our schools on, and so they are weighed twice at year R and year 6. And so there's obesity and weight management is really, really difficult. You can't just blame it on one thing. It's a very complex situation. Fast food, marketing, parental knowledge, it's vast. I could spend an hour listing things. Why we think it increases between those ages is actually access, probably, to unhealthy food is a big factor. Reduction in physical activity. So there's a lot of factors, risk factors, that all work towards, but what we tend to see is that it does increase between those years towards that, and then continues to increase into adulthood. I suppose there's quite a lot of research on it. We've got a physical activity lead who's also childhood obesity. We're doing quite a lot of work. I know this isn't exactly the question. From pre-birth, birth upwards, working with education, working with our health colleagues to mitigate. One thing that we've recently, a big factor, which is a good thing that we have actually improved for Portsmouth, is breastfeeding. We've got an infant feeding strategy now that's being rolled out. It's a joint one between the NHS, the ICB, ourselves, working across the whole patch with our providers as well. And we are seeing an increase in breastfeeding, which had very low uptake, which is a mitigating factor. We obviously try to do what we can and work very closely with schools on healthy eating options, healthy school meals, but also we're doing a lot of work in, I mentioned earlier, the community development work we're doing. At the moment, it's focused in Paulsgrove, Portsea, to some of our more deprived areas, working around healthy eating, shopping, diet, physical activity. So we are targeting lots of different work because it is quite, as you know, Kathleen, it's a very complex environment, and it's a national problem that is heightened by deprivation. So you see a direct correlation in childhood obesity and adult obesity in more deprived areas, and we're trying to mitigate against that. But you can see we do, for instance, something we've worked on recently, been working on, we have a no marketing or brands on our own council billboards, particularly working also around fast food outlets not being allowed to be opened near our school areas. There's so much work going, but I mean, I think it is a national problem and it's complex. We're all trying to work at it, and I do think that you can't tackle it locally alone. It has to be a national, well, it has to be an international, national government, regional and local issue, which we are working on. Don't think it completely answered your question, but if we had a direct silver bullet, it would be straightforward. We would do it. We do get very little funding, and it is really important, which is why we have, as you know, because you sit on our Health and Wellbeing Board, what we call our causes of the causes strategy, because you can't even, it's not just intervention there. So children who do reach levels when we are measuring at year 6, weighing kids, if they are showing likelihood of obesity, we are providing a direct service if their family accept it. But the reality is this is a societal problem.
I sort of have a supplementary really in respect of free school meals. Do we know if there's any relationship between the figures for increasing and free school meals? Is there any relationship?
With obesity?
Yeah. Do free school meals improve it, or does it make no difference, or does it make it worse?
I don't think you can directly correlate. However, we're doing a big piece of work to actually encourage take-up of free school meals. It's one of the problems which we have in Portsmouth, which became really clear during COVID, because we were actually obviously using that data, is that actually not all children who are able to receive free school meals, not all of them are actually, their families are not actually asking for them. So we're doing a big piece of work to try and get as much data to correlate, to actually encourage an uptake, and we've just had a bit of a breakthrough on that recently. So we are trying to encourage, and that also depends on whether the free school meal is a healthy option. So again, it's working with the schools to actually, and this is a big focus nationally, to try to get school meals. But again, it's a lot of choice, and there's stigma for children of actually. Would you rather didn't say that? Yes.
The only thing I would say, I think it's a really good question, but the only thing I would say is we've had universal free school meals in Key Stage 1 for years. And so if there was a correlation, I think it would be evident now. Although the universal entitlement to free school meals in Key Stage 1, as we come back to what Helen was saying, is the fact that a lot of people don't want to take it up. I'll be honest, from my experience of being a primary school teacher, a lot of this is around a parental choice, but also children's choice, like changing over the generations, like, you know, my mum telling me to eat it or not have anything. And but also I saw that as a teacher, is that kids going, I don't like vegetables and I don't like fruit, full stop, and the parents supporting that. Quite, you know, that, well, she won't eat anything except for sweets and crisps and stuff, you know. So I think that pattern's been coming in over the last few decades, to be honest. And also, having just gone out this morning to buy some healthy food, it is much cheaper to eat unhealthy food.
The food industry has a lot to blame, because that's the thing is, we do know that, and that's government are trying to start tackling that now. But the food industry make the most unhealthy food the cheapest option, and if you are a family in poverty, you know, buy one get one free, cheap, very highly processed lasagnas, or, you know, are the easier option. I'm not saying kids will eat lasagna, but you know what I mean. The trouble is, the unhealthiest options are the cheapest, and if you are trying to feed your family on a very tight budget, you are going to want to, unfortunately, buy that food, which doesn't help, and it's full of salts and additives and sugars. That's what.
Any other questions? Oh, yes, go for it, Susie, and then Matt.
I just want to make a comment because I think, and Graham highlighting this is really important. In all the years that I was cabinet member, this was the single most shocking thing for me. Is I remember the first time I read those stats, and I was like, no, this has got to be wrong. That we cannot have this many children who are being, categorised as obese, and that because of the outcomes for the rest of their life, and that's why it's so important. I think that's probably why you picked up on it. And I just think the complexity of it is a challenge to anyone. I mean, I agree with everything that Helen said. The other thing I would add, though, is the change in the curriculum. Because, the narrowing of the curriculum and the removal of the amount of freedom, particularly at primary school age, which teachers had to take the kids out on a blustery day just to write a poem about the wind or whatever, it's gone. And what we're finding is that even when we've got opportunities for kids to do physical activities, like free stuff that came with the sailing and all the rest of it, is that schools say we just can't. We have to plan our timetables, and actually we have one opportunity per week or two, whatever it is now, to do physical activity, and the rest of the time we can't. And if you then add on to that the fact that maybe a family doesn't prioritise playing in the park on the way home from school or going out, and of course kids don't go out nowadays until they're in Key Stage 3, I think it is a complex thing. But I do agree, it is the wicked issue, as they used to call it, and it is truly shocking because of the, as I say, the outcomes for everything, for learning, for work, and obviously the more direct health related stuff. So there's no question, it's just adding to the... Yeah.
In year R, children are running around, and that they're all in nursery, they are all running around, very active as they progress in age, and at school they are having to sit down to study. We've perhaps forgotten the importance of play and physical activity and moving, and unfortunately the NHS, I know James is coming after us, is picking up the costs.
Thank you. Hi, Helen. You mentioned earlier about the uptake of people committing to stopping smoking, and the data in the report is really amazing. Really, the wellbeing service offering that the 12 weeks, and the success rate in that 41% for Q1 and 47% for Q2. It's really, really great. My question is, how do you measure this success going forward? Are these people contacted in the future to ask if they've continued to stop smoking?
It's a really good question, and I would like to say we managed to make it to the news last week, I think on the back of this paper actually, the success. I do think it's important to note that, much like substance misuse, government decided to put more funding. So you'll remember there was a national plan a couple of years ago to encourage and try to really get to a smoke-free generation. It was a national policy paper, and on the back of that, additional funding was committed, and we have seen now we're just about to go into the second year of that funding. That has been really helpful because obviously we've been able to increase the number of staff we have we have an in-house wellbeing service. A lot of councils commission that out. It's been more flexible for us to keep that in-house. We've managed to increase our staff count, which has meant we can go out more. We've been doing a lot of work on evaluating the service offer, and also working with people. We've just done a huge piece of work, vaping in children and young people. And so we've been able to evaluate what's working, what people want, and we've been increasing that opportunity, hence like the work in QA and the Pompey Centre. So there's a national way of measuring this. You could challenge that, but basically there is a service offer. It's a national, to a certain extent, it's a national one-size-fits-all. How you deliver it can be adapted. So we do both opportunities through group work, telephone support, face-to-face, one-to-one. We do all of that, and when you come in or get referred, you can either self-refer or be referred by a healthcare professional. However you come in, you get triaged, and then the best service offer that you would want, you get. We do basically, it's a programme where you are seen or spoken to weekly. You set a quit date. You then are supported on that quit date however you want. That could be through, obviously, stop smoking drugs. It could be medication. It could be, you know, all of the range. It could be vapes. We do a lot of work, and that has actually really helped improve our uptake on swap to stop. So people basically given vape kits. You can use, chewing gum, any of your choice. You are also then monitored through, so we do check through, I've forgotten the word, what do we call them?
CO2 monitors.
CO2 monitors, thank you, Alan. And so we do check, and then you are monitored at the end of your quit attempt. So obviously we know that people often have to make more than one quit attempt, but a successful quit is when you have quit at that period of time. But again, you can come back at any point in time, and we see it as a positive because we know that once people start to quit or make a quit attempt, they're more likely to quit. It might take them 2, 3 or 4 times, but we are seeing a lot of people managing to quit through vapes. I know people have views about that, but the current evidence is clear that vaping, although possibly not without some harm, is a lot better and a lot less risk to your health than smoking. So that's been hugely beneficial since the government have allowed the use of vapes to be used. We use obviously, we don't just give anybody any vapes. You know, we're not talking about some of the vapes that are available on the high street, in the vaping shops. They are they are the acceptable vapes which are monitored, so they are acceptable, legal vapes that are used in this country as a stop smoking support. So that's how we're doing it, and it has been really great. And we are seeing a reduction in the prevalence as well. So we're about 11% now smoking, and actually we know also we're now focusing on on our population who are very hard to reach, but also are more likely to smoke at higher levels. So although 11% is the current whole population, we know that people with substance misuse, those with substance misuse, mental health, those that are living in our more deprived communities are more likely to have a higher rate, possibly up to 40%, and we're actually specifically targeting. So we've now got Swap to Swap and Stop Smoking Service offer in Alan's services, substance misuse, working with our mental health provider, working with the hospital, and working through our community development work in those harder to reach communities. So it's targeted.
Thank you, Helen. That's incredibly positive, and it's great to hear. I'm not sure this is the place to mention this, but I will mention it anyway. On the PCC website, there's a banner on most of the pages saying advertising to quit smoking, feel better. Yeah. What I've noticed is when you click the button for the free support tab there, it goes through to a page that no longer exists, and that is on the using a desktop computer and a mobile. So I just thought I'd raise that.
Thank you.
You're welcome.
Yeah, a different area of the paper. So section reproductive health. So there's been a really significant change in the per 100,000 diagnosis rate for SDI, which is I know that historically Portsmouth has been on the sort of higher levels, as you can see on the charts, but that's quite dramatic, the change. And I know that there's been sort of campaigns and work done on it, but there's no commentary. Are you able to give a bit of a commentary around that, please?
Yeah. Obviously we have contracts with primary care, community pharmacies, so you can now get STI testing done by post, and that has made I think that's made a big difference, because it's a lot easier. You don't have to necessarily go into your GP or to the STI clinic. You can actually do it online or by post. You still have to obviously send your specimen by post, but you can do it without having to go in. We've also been working with the Terence Higgins Trust who've been working with us with the Royal Navy for the last 2 years, and that's had a huge increase. There's a lot of work that's focused, although starting with HIV testing, so it's now opt-out as opposed to opt-in. So when you are so QA now, if you go into A&E and have bloods taken, you are automatically tested for HIV, unless you say you don't want to be. But you basically, by post, you can do the whole gamut of STIs. So a huge focus on increasing uptake of testing, and that can then sometimes also then show an immediate increase in the numbers, but it's had a beneficial impact for us. So lots of ways I can get something from Hanover if you'd like more information, but it's really, really focused work with the providers and also with the options. And I think it's just giving people choice of how they can be tested.
And those changes have been made across the country, haven't they? But they've impacted us disproportionately.
Not
So is that
every hospital? So some of those are in a, I would say, not everywhere. So for instance, testing, opt-out testing for HIV is happening across the country, but slowly, because we've had to high-risk areas first. We're in the second wave, and so they haven't, because it's quite a lot of work to be able to, because they have to increase, obviously, the ability to do the testing and the lab capacity, so that hasn't been done. The Navy one's an interesting area, because I was quite shocked and surprised, because it was nationally, I think it's okay, because this was in the press, I can say this, nationally, all the forces, so that's the Army, Navy and the RAF, there was no testing available within their medical services. So now that is available, because particularly with HIV, if you were identified as positive, you had to leave the force, and that has a huge impact. So it's a national now. Actually, it wasn't. I like to say this because it was a officer at the naval base in Portsmouth that took that work nationally to cabinet nationally to government with the Terence Higgins Trust, and that has had a huge impact. If you think that force staff are travelling all over the world to high-risk areas, it was pretty shocking that they did not have that ability. So they would have to go privately or to the NHS to be tested. So that's had a huge impact.
I've got a question on the suicide prevention page. I can see that we've fluctuated quite a lot over the years, and it looks like we potentially are on the way back up again, and we are slightly higher than the average national average. I just wondered what we're doing as a prevention to try and keep that figure down.
Again, not dissimilar from the drug deaths. We're talking about very small numbers. So obviously any fluctuation looks quite, it looks like it has a huge impact. There's work going on all the time. So in fact, and we continue to do that. So of particular, and some of it is in the pack, but I can get some more information for you. Huge amount of work with supporting bereaved families and friends immediately after, and I think that's a huge piece of work that has increased over the last year or so. So immediately, because that's again looking at the research evaluation, understanding the risk to other members of the family who are grieving. So a lot of focus on supporting those who are just in bereavement. Lots of focus generally around trying to improve mental health, as you know, well-being and decrease. Lots of focus nationally. I would like to say we haven't had to do that recently, but I'm aware other local authorities around. So if you get they're called places that become known as suicide, there's huge focus. We work very closely with the rail company, the police and others, and particularly obviously the coroner to get, and it's probably been the last 2 years I think we've been able to get immediate data, because obviously the most important thing is to put the mitigation prevention in. Immediately you get the information. So we do now get the pretty live data post so that we can do intervention. So a lot of focus we are and have seen through, and I think this has been a national issue, through when you have poverty, you tend to see an increase in male adult suicide, so a lot of focus on people not known to services. So, you know, all of this is about pulling all of the intelligence evidence in and then targeting the interventions. But there is a lot of work. I mean, we do have a strategy, it's been to Health and Wellbeing Board, which is to get to zero, because any death by suicide is tragic and we wouldn't want. So a lot of focus, but that's what we're aiming for.
Any other questions? Oh, Graham?
It's me again, a different topic. It's so what on joint working, planning, transport, housing and licensing, your section there. I mean, I'm obviously aware of what you're doing in transport, because obviously shadow transport. The planning one was one that I was interested in, because we're obviously, you know, the local plan has been an ongoing saga. And I was curious about the statement of common ground, which you mentioned there. So there's two questions. Can you give us an example of some of the things in that statement? And to what extent can we impact policy between iterations of the local plan? You know, can we do stuff in between time, or do we have to wait for the next iteration of the plan, or can we still do something to get stuff in now? How does this work? So two questions really. What is some of the areas being developed in the statement of common ground, and can we just put stuff in before the plan or after the plan?
Apologies. You're very aware of the work we're doing currently on air quality and impacting on transport. So it comes under what we call health in all policies approach. So the team, we've got a very small team, as you know, Graham, but we've got one person working in this area and it's the long-term planning where we try to influence the planning process. We're very lucky here because we work really well with our planning team. They're very amenable, but it's what we can do within the law. But it is, with the opportunity, there is quite a big evidence base on trying to, which is under health and all policies, of where you can make decisions that try to mitigate any negative impacts on health from a planning procedure, because you can't stop development, you can't stop business, but it's where you can mitigate. That's very set, and that's what the team do. So they will also have the opportunity, if there's any big planning applications, the planning team will come and ask them if they've got any suggestions, but they will also then put feedback into the planning, which they've done recently, because obviously the plans are coming. I can't remember, have they been agreed already, the current planning guidance? Has it come? Is anyone on the planning? Okay, I'm sorry, I should know this, but I know they have, so they feed in when the plans are being looked at, but they also have the opportunity when there's actually a planning application. Is that what you mean?
Yeah, I mean, let's give an example. I mean, I'm not sure the train of thinking, but for example, developments having permeable space, you know, in a big development, or places that absorb water, because if we have water and drainage that produces pollution, that, you know, it's the chain of things you get pollution, and also the damage of floods, etc. I mean, my sort of personal bugbear, which I probably shouldn't raise about, but you know, I just irritated when I see people paving over their front gardens, you know, without permeable surfaces, because, you know, the amount of runoff that creates. And actually, in some roads where you've got great long swathes of it, the amount of water that comes off into the road is a problem. But in developments generally, if you don't have, you know, permeable roofs that absorb water or slow the flow of water, it then overflows the drainage system, which then pollutes the water, which then creates a health problem, because, you know, people are swimming in, you know, in Langston Harbour, etc. So that's my sort of thing about how can we do things like that.
I think you're giving us too much, expecting too much. So we are, obviously, our job is to look at the evidence base. However, that comes under environmental impacts, and there is a whole legal process when planning when that has to be done. That's slightly out of our area. We're looking more at opportunities to improve, for instance, like community safety, how you build, lights, things like that. So, but also improving air quality, reduce, you know, we're not at that level of expertise in terms of the flooding. There are others who do that. But we do have access, and they are asked to so we are often a local conduit into the UK Health Security Agency if there are very, very specialist needs. And there is a there are expert teams centrally who do some of that work, particularly around chemicals and environmental impacts. But that's a little bit over our abilities. We are good, we're not that good.
I thought I might have got a bit over the top on that one, but I just think it's making these connections and things like that. I mean, one interesting thing that it shows you what I do on a Friday night, get to my age. I was watching Monty Don's Grindland Gardens. That's my major excitement on a Friday night now. And there was this fascinating development of an old factory that they actually converted into a park. They used the structure to create a park. So that's about using development opportunities that might have been different, i.e. demolish and build something else, but to create a green space in something that probably you wouldn't have even thought about as a good green space. So that was, I thought, a fascinating example of being innovative.
Aware of the greening agenda in the council, so a lot of that is happening. Felicity Harris she's not with Public Health, she's sitting in corporate, but she's doing a huge amount of work which we support around the greening agenda. It was in our annual Public Health report last year. So we are putting in lots of bids with Felicity to get money to plant trees, because that is a mitigating action in terms of flooding.
Any more for any more? All good. That was a fantastic report. Thank you so much for that. You're free to carry on and stay. If not, you're free to go. Thank you. So agenda item 5, as notified by email this morning, if you haven't seen already, Tracy Redmond is unable to attend the meeting today due to operations pressures. She has offered to answer any of the panel's questions by email, or we can jump this agenda to the next one if anyone particularly wanted to have her here in person. I'm open to suggestions. Does anyone have any questions following the report?
Well, I did have one question that I was going to ask, and it relates to the good figures about the turnover of ambulances at the hospitals, which is 45 minutes and then they leave. Because obviously 2 reasons. One, ambulances are needed out to collect patients. You don't want them sitting in hospitals waiting, and also sitting in the back of an ambulance is probably not the best place to be if you're unwell. But what I wasn't quite clear was whether, good though it is, it's really moving the problem a bit further up the stream, so that what happens is people are just sitting in corridors waiting for care rather than being sitting in the ambulance. I mean, I think it's good to have the ambulance away, but that was the sort of question I was going to ask, but someone else might be able to follow
We can
this up at
definitely
some
note
point.
that down, because obviously, Graham, you might not be here
Well, no, I don't.
next time, so we
Depending,
can email that, Matt.
Do you, not the previous meeting, but the meeting before, they came in and spoke about this, didn't they?
Yeah.
It was the fact that they were trying to stop people that was infectious going
Yes.
into and sitting and waiting. So they were trying to look at different avenues that they could take, and that seriously impacted the
Yeah.
the waiting times, didn't it?
Yeah, it did. On previous meetings. Does anyone have any other questions relating to the report? No? There we go. I think just email that. And then just, yeah. Yeah, perfect. Okay, then we're on to the final agenda item. It's over to you. Assume that we've read it, and then, yeah, just a brief summary. Thank you.
Hello, everyone. I mean, the main figures in the report is that we're obviously in a busy period at the moment, so you'll note that in October we saw the highest number of GP appointments in the area on record in 1 month, and that was 25,000 higher than the year before. I think a few points to note is that we reckon circa 50% of those appointments were urgent cases. So GPs are dealing with more urgent issues on the day in the practice. And I think the ability to do that really helps the rest of the system in terms of containing that demand within the primary care setting. I think the other thing to note is that alongside general practice appointments, we continue to see a significant increase in the number of people in the city using pharmacy first as an alternative. Not just to GPs, but also I think A&E in terms of sort of minor illnesses and how they present. And also I think around pharmacy first, it's not just your minor illnesses. We've also expanded it to the management of urinary tract infections and other complex conditions as well, and things like oral contraception. We've maintained the reporting of the data in the format requested, so you can see practice by practice, year-on-year difference. Some significant increases, Craneswater, Kirklands, Portsdown, and Westlands, clearly all going in the right direction. But we've also seen a reduction in some of our larger practices as well. That doesn't necessarily mean they're less efficient. It might be they're better at dealing with some of their demand as it presents into the practice. The other thing to note is that from October, I reported this at the last committee, we extended online appointments 10 hours a day, 5 days a week. In some instances, we've seen a 62% increase in the number of online appointments versus the same period last year. And I think the fact that we know for November and December, they will also be really high months in terms of activity. It suggests that online is a route that people are utilising in the right circumstances. The only other point in the report to reflect is we held a dentistry summit in November at the Dental Academy. We used that to really reset the strategy for dentistry access over the next couple of years. There are a number of procurements already complete for the city, which means we'll have more NHS dental providers, and we have one more planned for the next year. I think the other thing to note is clearly the formal status now of the dental school is to be congratulated, but I do think the dental school needs support in ensuring they get a sufficient number of trainees by which they can open the doors in October as well. So lots happening in terms of operational services, but lots happening in terms of strategy for the future and delivering a more sustainable service offering.
Yeah, thank you. I only had one question actually. So with the GP practice appointments per 1,000 patients figures, you've highlighted, and I sort of wrote down here about Craneswater and Kirkland surgery in particular having very high increases, which seems like a very good thing, obviously. Why is that so different? Why are they so different from the other figures? Is it just a case that they've got like one or two extra, you know, obviously these are one or two extra new doctors, or they've been able to fill vacancies? Is that the reason why, or has there been a specific another reason?
So I think you can see from the stats the GPs are working harder than ever before. I think for some practices, success in recruiting additional doctors. So, you know, traditionally, Portsmouth had one of the lowest number of GPs per head of the population. We've improved that over recent years. So I do think it's an increase in capacity. The other thing we have done across all of our practices in Hampshire and the Isle of Wight is we've commissioned additional same-day access appointment capacity as well for a locally enhanced service. So that will increase the number of cases seen on the day. I think the other thing that's probably happened is that with our additional roles in primary care, patients have choice now in terms of whether they see a GP, a nurse, a pharmacist, a physio, or a social prescriber, depending on need as well. So I do think it's an increase in capacity and more imaginative ways in dealing with that capacity to ensure that more patients are seen on the day in different settings.
Thank you. I was told that you could provide a verbal update on the situation regarding diagnostic facilities at Oak Park in Havant, because they've been closed down with no reference to any of the local GP surgeries. They were completely unaware. So could you give an update?
Yeah, happy to. So the decision to cease provision was made by the provider without endorsement of the ICB. They've requested a change to their contract, and within that change is a wish to remove services from Oak Park, which we haven't supported. It's a very live issue, so we're in contractual conversations with that provider in terms of their current provision and what that means in terms of transition in the future. We have put in place contingencies by which we'll support GP practices in the area in terms of their ability to refer to other diagnostic services as well. We are really disappointed by the way the provider has handled it, both in terms of their prior notification, their clinical engagement and their patient consultation as well. But we are committed to maintaining services at Oak Park, and we are exploring alternative options with other providers in partnership with NHS England as well. We know it's difficult because that was a good local facility that was accessible, so we need to make sure that we're recognising some of the challenges in terms of travel. But also I think there's a missed opportunity here if we don't resolve the issue, which is actually that facility really demonstrates the strength of neighbourhood health. If we can have more diagnostic facilities in primary care and in the community, that really helps us to deliver a neighbourhood health model as well. So to say that obviously we're in conversations with the provider, we're looking at the contractual routes by which we can manage the issue, but to give this committee assurance, we have put in place contingencies in terms of alternative referral routes, and we are looking to maintain services at the facility in the future.
Can you explain a bit more about what those contingencies are? Because at the moment, people are being referred to QA or St Mary's, which involves bus journeys, walking, taxis, and it becomes expensive, and then people aren't doing it, and then not going to their appointments. So.
Yeah, so we're in conversation with other similar providers, because we obviously, whilst it's useful for patients to have the alternative of the hospital, that sort of takes us away from the intention of the service model in the first instance. So we are looking at other providers who can operate services in that space. Yeah, we are looking at that. I can't confirm that at this stage, but we are having conversations. Now, the pace at which we do that will also link back to the conversations we're having with the existing provider and how we can transition from where they are to a new service in the future. So I am happy, Chair, to follow up with more detail, because I know this is a concern when that's firmed up. I have to be careful what I say in this instance, given the conversations with the provider. But I think the two assurances I can give is, one, we're seeking an urgent contingency, and two, there is a commitment to maintain services in that area as well.
Have you got any idea of timescale of when this might be resolved or the contingencies be in place?
Yeah, I mean, again, we recognise the urgency and commitment to resolving as soon as possible. I'm happy to come back with more certainty on that, if that's helpful.
Any other questions from this report? No? Oh, brilliant. Thank you very much. Thank you for your time. The report is noted. Okay, here we go. Agenda 7, dates of future meetings. There is only one that I can't attend, so I'm going to see if Judith can deputise for that. But is everybody okay with the others? Brilliant. Okay. You all right? Yeah? I'm going to close this meeting then, unless I've forgotten anything. 2:20. You're free to go and get wet.